everyone. Today it's an interesting topic, MGRS, which is a relatively new concept. I think let us start the talk. So, thank you.
At the outset, I'd like to thank the organizers of ISN Southern Chapter 2023, especially Professor NGK sir, for giving me this opportunity to speak on a topic which I'm very interested in working on. So this is MGRS, to treat or not to treat, looking beyond the kidney. My outlines would be a brief classification of MGRS, how to work up a case of MGRS, what is the evidence about the therapy for MGRS, what are the protocols we follow at our center, renal transplantation in MGRS, is it safe, and a case vignette with intrinsic facts. So the first case of multiple myeloma was noted in 1844. It was a wealthy grocer who presented with bony pains and pedal edema. And he typically said that the urine, when stained as linen, it used to make his linen stiff. Dr. William McKentry examined his urine and found an interesting thing. He did a heat test on the urine, and on further boiling it above the boiling temperature, he found that the protein disappeared, which then again precipitated on cooling down. He sent this urine sample to Henry Benz Jones, who was a chemical pathologist, and he analyzed this urine and he discovered a new protein and labeled it as Benz-Jones protein. This was only later, in 100 years later, found out to be kappa and lambda light chains as we know now. So this is Gerald Morris Edelman and this is Rodney Robert Potter. They were awarded the Nobel Prize in 1972 for the discovery of the structure of immunoglobulin, and we now know that immunoglobulin is composed of 2 light chains and 2 heavy chains. The International Myeloma Working Group classified plasma cell disorders based on the M protein in serum electrophoresis, on the percentage plasma cells, and on end organ damage. This entity of MGRS was taken up by the International Kidney and Monoclonal Gammopathy Research Group, IKMG group, in 2012, and they now reclassified this based on 3 clones: plasma cell clone, lymphoplasmacytic lymphoma clone, and B cell clone, and they classified patients based on a minimal tumor burden and target organ damage, and the criteria was changed to slim crab criteria. Based on these 2 criteria, now we have 3 different types of people, and MGRS belongs to these 2 groups of patients who do not have a target organ damage but have a renal disease. So it can be now defined as a clonal proliferation of B or plasma cells or LPL cells that produces a nephrotoxic monoclonal immunoglobulin, however not meeting the hematological criteria of malignancy. Why so much of fuss for this MGRS? As compared to MGUS, it has a faster progression. The risk of progression to kidney failure if left untreated, they do not respond well to the usual immunosuppressants, and they have high rates of recurrence after transplant. IKMG classified it in detail into 3 groups: organized monoclonal immunoglobulin deposits, which may be fibrillar, microtubular, or inclusions; non-organized monoclonal immunoglobulin deposits. Under this we have MIDD and PGN-MID, and no deposits wherein you have C3GN and TMA. Most of these lesions affect the glomeruli, but certain lesions can affect all the compartments, like in MIDD, amyloidosis, and cryoglobulinemia. Only renal lesion which is now considered as a myeloma defining lesion is a myeloma cast nephropathy. Under the fibrillar lesions, we have AL amyloidosis, which is Congo positive, usually lambda, and fibrils of 8 to 12 nanometer. Fibrillary GN fibrils are larger in size. Now we have a IHC, that is DNA JB9, and it is usually polytypic. So if you get monotypic fibrillary, it's better to do a pronase digestion on paraffin IF. The 2 microtubular lesions are immunotactoid, wherein you get monoclonal IgG1, and type 1 cryoglobulinemia, usually it's IgM, and on light microscopy, you have characteristic intracapillary pseudothrombi, which is fibrin negative with influx of macrophages, and this microtubules have a typical fingerprint or a comma-shaped pattern. The most common inclusion is light chain proximal tubulopathy, which can be crystalline or non-crystalline. Crystalline is usually kappa and non-crystalline lambda. Fanconi syndrome is more common with the crystalline variety. The other rare variants are crystal storing histiocytosis and cryocrystalloglobulin nephritis. MIDD can be LCDD or HCDD, and the typical EM picture is electron-dense, powdery, punctate deposits along the basement membranes. PGN-MID is usually IgG3, with kappa, and on EM you get typical granular, electron-dense, non-organized deposits in the subendothelium, mesenchyme, or epithelial location. When you get a C3 glomerular nephritis with monoclonal gammopathy, it is better again to do a protease-digested paraffin IF to unmask the monoclonal immunoglobulin. Now, this is a series of 48 cases of MGRS from AIIMS, New Delhi, and the most common lesion was AL amyloidosis followed by LCDD. Now, if you look at the characteristics of the monoclonal deposits, lambda light chain is more commonly seen with AL amyloidosis, non-crystalline LCPT, and TMA with monoclonal gammopathy. Kappa is most commonly seen with LCDD, crystalline LCPT, and PGNMID, whereas other lesions can either have kappa or lambda. Now, coming to the hematological diagnosis in various lesions, 90% cases of AL amyloidosis, LCDD, and LCPT will have a circulating monoclonal immunoglobulin as compared to only 7 to 17% in fibrillary GN. And most of these lesions, multiple myeloma is a rarity. In most of the lesions, the nephropathic clone is a plasma cell. Exceptions are immunotactoid and cryoglobulinemia, where the most common lesion is a B cell clone. Now, coming to the test, when you have a MGRS lesion, you have to do a serum protein electrophoresis, immunofixation electrophoresis, serum free chain light assays, bone marrow examination in all patients to look for percentage plasma cells and immature plasma cells, trephine biopsy to detect CD138 positive monoclonality by immunohistochemistry, and bone marrow flow cytometry to detect the pathogenic clone. Now, if all these tests come negative, then we have a few additional tests, like we can go for a PET-CT, thorax, abdomen, and pelvis, and a flow cytometry of the peripheral blood to detect small clones of CLL or MBL. Now, we all know serum protein electrophoresis, but there are certain common conditions which can produce a false positivity, like severe iron deficiency anemia, nephrotic syndrome, hyperlipoproteinemias, and false negative results are commonly seen in HCD, light chain monoclonal gammopathies like non-secretory myelomas, and LCDD. Immunofixation electrophoresis is more sensitive. It can determine the type of your heavy chain and light chain. However, you cannot quantify the M protein. All cases of MGRS at diagnosis and follow-up require a serum-free light chain assay. The normal values of a kappa lambda ratio is 0.26 to 1.65. In renal failure, it is 0.3 to 3.1. Now, how do we assess the hematological response? We have to know this terminology called as DFLC, which is the pathogenic light chain minus the non-pathogenic light chain. Now, out of all the criteria, what is important for the nephrologist is the VGPR. VGPR is very good partial response, wherein there is more than 90% reduction in your DFLC, or your DFLC is less than 40 milligram per liter. Achieving a VGPR or above is associated with better renal outcomes. However, certain lesions like PGNMID, you do not have a monoclonal immunoglobulin. Then how do you assess the response? Only way is to look at the renal response, that is the proteinuria, and the renal dysfunction. We have a lot of agents now available in our armamentarium. We have cytotoxic agents, proteasome inhibitors like bortezomib, immunomodulatory agents like thalidomide, monoclonal antibodies against the B cell clone is rituximab, and against the plasma cell clone we have the daratumumab and isatuximab. Daratumumab have been studied in PGNMID patients and found to be effective. Isatuximab is successful in myeloma patients. A trial is ongoing in patients with MGRS. Now, this is the largest series of MGRS, 280 patients from 12 countries, published in American Journal of Hematology in 2022. They divided these patients into amyloidosis and non-amyloidosis group. The amyloidosis group had more proteinuria. Non-amyloidosis group had a lower eGFR. Clone-based therapy was given to 87% patients, similar response with different therapies. However, autologous stem cell transplant was found to have a better response as compared to other treatment modalities. There was no difference in the overall survival, but patients who attained VGPR had better survival, patients who attained VGPR had a better renal response, and patients who had a better renal response had better survival. Now, this is a series of 53 LCDD patients, wherein they found that achieving VGPR improved the GFR, and majority who had VGPR became dialysis independent, and the most important predictor was attainment of VGPR. So how do we manage AL amyloidosis or MIDD at our center? We look whether the patient is eligible for HSCT. If they are eligible, we give 3 to 4 cycles of bortezomib-based therapy, followed by a melphalan, high-dose melphalan and autologous stem cell transplant, and at day 100 we assess for the VGPR. If patient is not eligible, then we give them bortezomib-based therapy followed by assessment of VGPR at end of 6 cycles. Although studies have shown that autologous stem cell transplant have theoretical benefits, the only randomized controlled trial comparing these two modalities found a lower survival at 3 years in autologous stem cell transplant patients. We have a lot of therapies and regimens available. Most commonly used regimen is the VCD regimen or the CyBOR-D regimen, wherein we give cyclophosphamide, bortezomib, and dexamethasone. Now we have a new regimen called as the DARA CyBOR-D regimen, and this in the Andromeda randomized control trial was found to have better outcomes. There is an entity to understand AL amyloidosis with a low FLC burden, wherein the DFLC at diagnosis itself is less than 50. These patients have less cardiac involvement, more renal involvement, but better overall survival and renal survival. And in these patients, attainment of a stringent DFLC criteria, less than 10 milligram per liter, is associated with better survival. Now, fibrillary and immunotactoid GN, should we treat or not? This is a series of 73 patients, wherein patients with monotypic deposits were more likely receiving clone-based therapy, and those who received clone-based therapy had a better outcomes. What we have to be careful is when we have a fibrillary or immunotactoid, we have to rule out other conditions like HCV, and in fibrillary, there are certain autoimmune diseases which are associated, of which the most common is Crohn's disease. How do we treat fibrillary at our center? We divide them into monotypic deposits or patients with polytypic deposits. Patients with monotypic deposits, if we can detect a clone, we give a clone-based therapy, plasma cell clone, then CyBOR-D, B cell clone, then rituximab. If there is no clone but only a monoclonal immunoglobulin, we look at what is the type of immunoglobulin. IgM, we give the B cell therapy. Non-IgM, we give a plasma cell therapy. And if there is no clone and no monoclonal immunoglobulin, we look at renal dysfunction and proteinuria. And patients who have severe renal dysfunction are given more therapy. Now, patients with polytypic deposits are treated only if they have renal dysfunction or proteinuria. Now, immunotactoid GN are associated with more detectable clones, and hence we treat them irrespective whether a clone is available or not. Now, this is a series of monoclonal C3 glomerulopathy, 50 patients in whom they found that renal response was better in patients who were given targeted therapy and those who attained a VGPR. This is a series of 49 LCPT patients wherein chemotherapy, patients who received chemotherapy had a better renal outcomes, and attainment of VGPR was associated with better renal outcomes. This is a series of 16 PGNMID patients at our center. The median eGFR was 35, nephrotic range proteinuria in 87% patients, and the most common light chain that we got was a kappa light chain. Only one patient had a multiple myeloma. None of the patients showed light chain restriction on immunohistochemistry, and we found that the most common pattern was an MPGN pattern. The most common heavy chain was IgG, and both kappa and lambda was equally found, and EM showed typical findings of PGNMID. However, we gave only therapy to 2 patients with a plasma cell clone-based therapy, and 38% patients progressed to kidney failure, the most important predictor being chronicity on biopsy. This is a series of 19 patients of PGNMID who were given a clone-based therapy. 16 out of 19 received a clone-based therapy. 50% patients had a plasma cell clone, and 50% patients had a B cell clone. And the renal response was very good, and all the 16 patients over a median period of 2 years did not develop ESKD. So what is the protocol for PGNMID at our center? A kind of a similar protocol. We try to find out a clone. If no clone, we look at the circulating immunoglobulin. If no immunoglobulin, then we look at what is the deposit in the kidney. If it's a B cell clone, we give rituximab. If it's a plasma cell clone, we give CyBOR-D. If no clone but a circulating immunoglobulin, IgM we give B cell therapy. Non-IgM we give plasma cell therapy. If no clone and no immunoglobulin, we look at the clinical parameter. If patient is having renal dysfunction and significant proteinuria, if it's a non-IgM, which is most likely in most cases, we give a bortezomib-based therapy. Should we treat MGRS in an ESKD patient? There are only 2 indications. One, if there are extra renal involvements like cardiac involvement in AL amyloidosis, or patients who are being planned for kidney transplant. Why? Because there's a high recurrence rates of MGRS after kidney transplantation. In this series of 30 kidney transplants in MGRS patients of various etiologies, irrespective of whether the patients received therapy before transplant or not, most of these patients either developed a histological recurrence or graft failure or mortality. Now, this is an interesting paper on 26 PGNMID patients who underwent kidney transplant with protocol graft biopsies. A high recurrence rate, 89%, most of the recurrence within first 6 months, and with only 20% patients having a circulating paraprotein. Graft loss in almost half of these patients, and the most important predictor was a delay in diagnosis of recurrence. I would like to end with a clinical case which we had a few months back. This is a 61-year-old female. She was a diabetic since 2017 with peripheral neuropathy, no macrovascular complication, hypertension since 2017, hypothyroid, presented with periorbital puffiness for 6 months. Her creatinine was 0.7 in Jan 2020, which became 1.5 in 2021. Dipstick was 1 plus in 2020, which became 2 plus in 2021. Patient had hypertension at presentation, no pitting pedal edema. Fundus examination showed grade 2 hypertensive retinopathy with no diabetic retinopathy. Labs showed a normocytic normochromic anemia. Other cell counts were normal. She had a good glycemic control. Creatinine went up to 2.8, no hypercalcemia. Urine routine showed 3 plus protein, no active sediments. Nephrotic range proteinuria with hypoalbuminemia. Normal size kidneys. Electrophoresis was sent, which showed a query band which couldn't be quantified. And urine BJP was negative, viral screen was negative. So what to do next? We decided to go for kidney biopsies. There were certain clues for non-diabetic kidney disease, like absent retinopathy, nephrotic range proteinuria with severe hypoalbuminemia, renal dysfunction and proteinuria in spite of a good glycemic control, and a suspicious band. We also decided to go for workup for monoclonal gammopathy. A immunofixation, electrophoresis, and serum-free light chain assay was done. We decided we'll wait on the bone marrow after looking at the kidney biopsy. The kidney biopsy showed nodular glomerular sclerosis, which was silver negative and PAS positive. So what are the DDs of nodular glomerular sclerosis? Most common, diabetic kidney disease, Kimmel-Stilln-Wilson lesion, that is class 3. We can also get it in amyloidosis, MIDD, fibrillary, immunotactoid, some rare diseases like fibronectin, chronic hypoxic condition, idiopathic nodular glomerular sclerosis. Our patient was not a smoker. So based on the stain pattern, PAS positivity, silver negativity, diabetic kidney disease was out. Then what are the possibilities? MIDD, fibrillary, immunotactoid, fibronectin, and collagen 3 glomerulopathy. Now out of this fibrillary, we have a stain called DNA JB9. If it comes positive, we can diagnose it. We don't have it at our center, so we couldn't rule it out. For fibronectin and collagen 3, there are IHC for collagen 3 and fibronectin. We do not have this at our center, so we couldn't rule it out. So we decided to look at the IF. IF showed IgG deposits along the periphery of the nodule, along the tubular basement membrane, and along the vessels. Few C3 deposits in the mesengium. And there was just trace kappa as well as lambda. So now what can be the possibilities? Fibronectin and collagen 3 were out because that is IF negative, except for collagen 3, which can sometimes present with a full house effect. Immunotactoid is IgG1. We don't have a subclassing, so we couldn't pick it up. We didn't have any differential, but it is usually kappa or lambda monoclonal. Fibrillary is usually polytypic deposits. If you have monoclonal deposits, then you have to do actually a pronase digestion. But here kappa and lambda were both equally traced. LCDD is out because there is no light chains. Heavy chain deposition disease is usually IgG1, a truncated IgG1. So then we kept our differentials as probably fibrillary, gamma, heavy chain deposition disease, and immunotactoid. EM showed the characteristic electron dense punctate powdery deposits along the basement membrane. So what is our diagnosis? Our diagnosis now was easy. Gamma heavy chain deposition disease. Now how do we look beyond the kidney? We did an immunofixation electrophoresis which showed a faint IgG lambda, a serum-free light chain assay which was normal, kappa lambda ratio was normal. We did a bone marrow which was less than 10% plasma cells. We did a trephine biopsy and on which there was mild plasmacytosis. We did a IHC on it which showed 20% CD138 positive plasma cells, but there was no light chain restriction, again pointing towards a heavy chain disease. What we should have done additionally was a bone marrow for a flow cytometry to be sure that it's a plasma cell clone, which we didn't do in this case.
So excuse me,
yeah,
please adhere to the time, please.
Yes. So MGRS, the diagnosis is now a plasma cell clone. We started a Cybor D regimen. How do we assess? We don't have a circulating monoclonal immunoglobulin based on proteinuria and creatinine. After 3 cycles, he had a partial remission of a nephrotic proteinuria and renal dysfunction and decided to continue further cycles at a local place. Before ending, we know this wire loop lesions are seen with SLE, but which MGRS lesion is associated with SL with wire loop lesions? A series presented by Nasser et al., a variant of PGNMID, light chain variant of PGNMID with no IgG deposits. They have more subendothelial deposits, less C1q deposits and wire loop lesions. Which anti-myeloma therapy can present with Fanconi syndrome? We know that when you have monoclonal gammopathy with Fanconi, 2 differential should be LCPT and LCDD. Rarely amyloidosis can also present. Lenalidomide is one drug which can cause Fanconi syndrome. The last one, which anti-myeloma therapy can cause a false positivity on electrophoresis? It's the new drug daratumumab. So we need a specific assay called as daratumumab specific Hydra shift assay, which will help to remove this interference. I would like to conclude by MGRS is a definition which has come up since 2012. We have a very clear differentiation into various lesions. We need to work up for a detailed workup for a monoclonal immunoglobulin, additional workup in specific entities like fibrillary, cryoglobulinemia, immunotactoid, and monoclonal C3 glomerulopathies. Clone-directed therapy is associated with better outcomes. Attainment of VGPR is associated with better renal outcomes. MGRS with low FLC burden, stringent DFLC response is associated with better outcomes. Targeted therapy against the hypothesized clone in cases where you do not have a nephropathic clone is associated with better renal outcomes. Currently, MGRS, except for amyloidosis, are associated with a high recurrence after transplantation, and management involves a multidisciplinary approach involving nephropathologists, nephrologists, and hematologists. Thank you.
Thank you, sir. Dr. Chakravarti, you may please honor Dr. Elenjickal Ilyas John with a memento, please.
Just I'd like to add one more point because I just want to conclude. Thank you, Dr. John. This is just because of these monoclonal gammopathies involving kidney, it's something always confusion in the classification. This is actually, you have 2 ends of a spectrum where you have a clear-cut myeloma definition, both hematological, and then you have a clear-cut caste nephropathy. And then we have another spectrum where you have monoclonal gammopathy of unknown significance, where it is relatively benign, where you don't have to really treat. But what about these people who have low immunoglobulin load and organ involvement like a kidney damage? So I think that's where this MGRS concept has come. Earlier, these patients, they used to treat immunosuppressive drugs which actually they don't respond to the, like other glomerular diseases, what you use, they don't respond. So that's when this concept of using these alkylating drugs in this MGRS, which they were a bit worried about the toxicity, but now it is clearly proven they actually respond very well to these alkylating agents. And all these people who fits into this criteria, where they don't have caste nephropathy, but they have a renal involvement, I think these are the people who should be treated with alkylating agents. Thanks a lot.
Sir, can you please honor Dr. Elenjickal? Thank you, sir. I call upon Dr. Tapoti Mukherjee, who will be deliberating on the topic management of hyperkalemia in patients with renin-angiotensin-aldosterone system, in short known as RAAS, and other drugs.